I'm a research assistant at ICS. On behalf of ICS, I welcome you all to our first Wednesday seminar of 2023 titled The Health Services Systems in China, Challenges in the Times of COVID-19. We are all aware of the clinical similarities between 2019 novel coronavirus and SARS, which is severe acute respiratory syndrome. However, China's health reforms have witnessed significant shifts, especially since SARS epidemic in 2002. The reforms have consistently striving for universal access of equitable health systems and yet have fallen short of delivering during the COVID years, which some of our previous seminars have also explored. This talk attempts to unravel the past and the present reforms in China and what it means for the future of health systems in China and lessons that can be drawn from other health systems across the world. It takes the Chinese health system as case in point to demonstrate the evolution of complex health systems and fault lines that exist and have been accentuated, especially in the COVID context. Our speaker for today is Madhurim Anandi, a fellow in Health and Human Development at the Center for Social and Economic Progress, New Delhi. She holds an MPhil and PhD in Public Health from Center for Social Medicine and Community Health, Jawaharlal Nehru University, New Delhi. She's held various positions throughout her career, including Assistant Director and Fellow at ICS, Senior Program Coordinator at Public Health Resource Network, Technical Consultant with the National Commission of Microeconomics, Health and Research Associate at Institute of Social Studies Trust. Her areas of interest include studying different health service systems, health policies, and inequalities in health. She has several publications in her name, which can be accessed in the chat box. Our chair, Professor Alkacharya, as you all are aware, is the honorary director of ICS and the chairperson of Center of East Asian Studies, School of International Studies, Jawaharlal Nehru University. She's been teaching courses on China, Chinese foreign policy and political economy to the master's and MPhil students and guiding doctoral students since 1993. She is the joint editor of the book Crossing a Bridge of Dreams 50 Years of India China and has contributed chapters to many books and journals. Her most recent edited volume is Boundaries and Borderlands, a century after 1914 Shimla Convention. She was also nominated by the Indian government as the member of India-China Eminent Persons Group and member of National Security Advisory Board for 2 terms. Before I hand over to Madhurim, I would like to invite Madhurim to share her perspectives on the challenges in China.
Well, looks like some glitch has occurred with our introducer. So I think she was 99% through with the introduction. If she is unable to come on and conclude, shall we proceed, Madhu? All right. Thanks, Sugandha. I think we'll wait for you to come back. And Shubhadeep, thank you for beginning the proceedings. And yes, a very, very warm welcome in this cold wave that is currently gripping China, India, Delhi particularly, and the first Wednesday seminar of 2023. So we have Madhu, who's been already introduced, and I think we could not begin our seminars for 2023 on a on a more relevant, pertinent, opposite theme, because for the last 2 months we have been completely consumed by this switch that China did practically overnight from what was described by Anand Krishnan from a zero-dash COVID policy to a zero COVID policy. There's just suddenly, there was no policy. Everything was opened up almost overnight. And thereafter followed consequences, which obviously were familiar to most people who went through the various phases of the pandemic. And it seems to be continuing. And the question really that, and I think I would like to give Madhu as much time. So I'm just going to say that we requested her to come in here to address some of the important aspects which surround this entire decision, namely, number one, what makes countries um, adopt different strategies and methods for coping with what is a pandemic, some of which are closely uh, closely aligned, some of which are quite different. So, how do countries make choices, and what are the factors that go into deciding various strategies to deal with such a highly infectious kind of a pandemic? And related to this, the other question, the larger question, basically, is that when when we have a pandemic, and clearly we saw a huge effort globally to look at the kind of vaccines that could be prepared to deal with this, and how they would be sent, distributed, sold in other countries, and what were the kind of issues involved in intellectual property, and the cost factor weighed against the human loss factor. In the light of that entire debate, we seem to be looking at a policy of developing vaccines in China that appears to have failed. That is to say, the indigenously generated vaccines, because clearly either the vaccine itself has failed, or the delivery systems have failed, or they've not inoculated enough people, for instance, the senior citizens. So how do so one is, of course, devising strategies, and the other is the actual administering uh, to a pandemic like situation. I mean, these are the two broad uh, macro questions, if you will, within which we would like to hear your thoughts about what really to make of this particular phase in the evolution of the COVID. Um, Over to you, Madhurima.
Thank you, Chair, and thank you, everyone who was attending this seminar. So I will just start with an introduction on keeping COVID-19 in the backdrop and looking at the health services system in China and the way it's evolved in the last 2 decades. The COVID-19 pandemic obviously has tested the capacities and the resilience of governments across the globe. It's also brought forth the entrenched fault lines within the existing health services in most countries. There have also been a range of responses by governments to meet the demands of health services and bridge gaps during the course of the pandemic. So you've had a spectrum of responses across governments, across countries. And why a country chooses to have a particular response has also been determined by various factors. Therefore, I look at China as a case, not specific to what's been happening in China that we can discuss later, but I'm looking at China as a case in the terms of what were the health service systems that were already underway in this country before the crisis, and what informed the response to the pandemic and the way it responded to the pandemic. The COVID-19 in a way opened doors to overcome a lot of path dependencies in a sense that these countries have. So for China, also, I mean, there have been reforms that have been incremental. There have been legacies because of which there's been resistance to change within the health service systems. And of course, there are structural interests also that characterize the sector. I would like to also emphasize that much of the data on China for the COVID years has been opaque. But whatever information we get is from the Western literature, and there has been some extent of China bashing, blaming because the origins of the virus was from China. So I would also like to put down here that in a sense, like all countries faltered during their response towards COVID infection and its spread. And this had to do with the structure of existing health services that were, in a sense, not perfect in most contexts. We also need to understand the structure of health services, and the way it evolves is deeply political. It's also linked to the social, economic, demographic, and epidemiological contexts, and also the way we are connected globally in these times. So, but we also have responses that have been deeply political. So I do not discuss why the pandemic started in the first place, because there are debates on its origins that have narrow perspectives, blaming China, and those stating that the complexity is beyond just looking at China, but also looking at emerging diseases in the context of the degradation of environment, urbanization, global capitalism itself. So a lot of things that lead to newer infections, new emergence of infections and outbreaks, which have pandemic potential, especially in today's world. So as a public health researcher and a China watcher, I kind of take China as a case and speculate where they might have faltered given the health service reforms they have undertaken in the past, and how their health services have evolved in the past 2 decades. To begin with, there are several components to health services. So you have governance, you have provisioning, you have financing, you have human resources, you have also regulation. So changes in each aspect, each systemic, we have to look at it systemically. So each of these systems, if you are bringing in reforms in one aspect of the system, like there needs to be a complementary change in the others too. But a lot of times what happens is that health services also reforms become incremental and not systemic. And these create challenges for system. So I will, just very few slides, but I'll just kind of share. So I hope everyone can see. So I just want to start with just some comparative indicators I'm giving this just to keep it in the background. Like if we are just to compare some of the very basic indicators between China and India over the years. I mean, the infant mortality rate is IMR and MMR is the maternal mortality rate. So basically these two are very sensitive indicators in terms of how a country is doing in terms of its health.
Sorry, Madhu, can you make it a slideshow? It'll become a bit bigger.
Oh, I'm sorry, it's not. Is this better? Yeah. So in a sense, I mean, it gives us a sense of how a country has progressed over the years, whether the health services, how the health systems have developed, and these indicators kind of tell us how a system is responding to its population. So we see if we see China and India in terms of the indicators, we see they started almost at the similar indicators in the 1950s. This is like just post-revolution, post-independence for both countries. But China progresses quite quickly over the years. And by 2020, we see their IMR has dropped critically to 6. And while we still have a high IMR of 27. And similarly, in terms of maternal mortality, we're still much behind how the way China is moving. So, I mean, this is just to say like what we are doing and where we are in terms of our responses. So I just go back to China again, and I'm looking at the systems separately. So as I said, health service systems are determined by various factors like the governance, provisioning, financing. So I look at provisioning first and what's happened here. So presently what exists in China is a mix of public-private facilities, but they have a dominant public sector. So private sector facilities at the secondary and tertiary level are mainly in Tier 1 and Tier 2 cities, while government health services are available across levels of care, so primary, secondary, tertiary, and they are the dominant health sector. So almost 80% of all outpatient and inpatient services are within the government health services facilities. So The private, of course, has gradually grown. So if I'll just show you the next slide. So if you see like the slide on the left, the figure on the left, so it gives us number of hospital visits. The red is the private hospitals and publicly owned is in green. So you will see that, of course, the hospital visits are maximum in the public hospital, but the private sector is gradually increasing. Similarly, number of inpatient visits we see is gradually increasing in the private sector also, but it's still dominantly public. What happened during the reforms, health sector reforms in post-economic reforms of China in the 1978 was that the government rolled back its investment on health and preventive and public health services. The primary health facilities, actually, many of them shut down due to underfunding, and epidemic prevention stations that had existed during the Mao years actually also shut down, and medical care became more focused on hospitals. So you had existing hospitals, but the primary level care services were faltering. The hospitals have seen a high growth, while there has been a decrease in facilities at the primary level. In the reform period since the 1980s, the primary level health facilities received negligible funding from the central and provincial governments. So after the collectives dissolved, they were left to their own devices and many shut down. It was only after 2009 when they took in like corrective measures, the focus shifted to strengthening primary level health services. And these were the course corrections that they underwent in the middle of the last decade. But the focus on reforms for public hospitals has been significant through these years. And there has been substantial growth of hospitals at the secondary and tertiary. So a lot of these hospitals, what was happening is that the hospitals were autonomized. So basically, there was no referral system that existed as it existed during the Mao years. So you had the primary level speaking to the secondary and the tertiary level during that time. So a person would actually go to the primary health center and then get referred if needed. But what happened during the last 2 decades was that the hospital, China became a dominantly hospital-focused had a dominantly hospital-focused health service system. So the referral system broke because the primary level services broke down. And much of the patients, people started accessing hospitals directly. So there was no, in a sense, gatekeeper for the flow of patients. So health facilities were more or less also left to their own devices. So basically a hospital, and as I said before, these are all public hospitals, mostly dominated by public hospitals. It's not like they were directly funded by the central or the local governments. They were left to their own devices to generate their own revenues. So by the early 2000s, almost 90% of the revenues were being generated from selling pharma medicines and diagnostic services, while only 10% of this revenue was coming from the government sources. So clearly the hospitals were, like, in a sense, behaving commercially. And physician payments and salaries were also coming from these revenues. So they were incentivized if there were more people, they were able to draw in more patients into the hospital. So one can see there's a skewed kind of system that kind of developed in China. There were also issues of irrational and corrupt practices. So you had prescribing of medicines, you had over-diagnostic, over-treatment. So these practices persisted mostly all through the last 2 decades. So in a sense, there was a rising cost of medicine, out-of-pocket expenditure increased, people were paying heavily out of pocket. The focus had completely shifted to curative services, and the primary level preventive services were completely neglected. And there were, very severe disparities and inequality across provinces. So these disparities existed across rural, urban, across provinces, across rural, urban, and even across within provinces also, there were intra and interprovincial differences across income group also. So of course, once there's a top-heavy system that emerges, you kind of also have human resources concentrated at a certain particular level of care. So most of the human resources started being concentrated within urban areas and at the hospital level. So in terms of paucity of resources in more remote areas and rural areas were very common. And the urban centers were where people actually went to access any kind of medical care. Then the SARS epidemic happens in 2002-03, and it showed the government's unpreparedness and the inadequacies in surveillance that could prevent outbreaks. So this was one of the biggest landmarks in the sense of the health services outcomes, and China post-SARS kind of put its act together. And since it also faced one round of global bashing around that time, it reinforced its disease prevention and control system. So it brought back resources back to the primary level and tried to build its epidemic surveillance stations again, started building back its primary level care services, primary health centers, trying to also increase the human resources at that level and direct a whole lot of resources there. This was also the time when, because out-of-pocket expenditures were high, they went through this whole financial reforms of increasing their insurance system base. So there were several insurance schemes, and they tried universalizing access to health services through these insurance mechanisms. And these insurance schemes were different. There were 3 different insurance schemes, one for urban employees, one for urban residents who were self-employed or unemployed, and one major health insurance scheme for the rural. So in terms of reforms, what China went through post-2009 was again trying to redistribute and rationalize the flow of patients by strengthening the primary health services, because this was important for them. There was heavy load in the hospitals in the urban centers of the provinces, and they wanted to redirect the heavy load back to the primary level so that there was proper referral happening from the primary to the secondary and the tertiary. So in a sense, they were trying to create back a 3-tiered system that existed during the Mao years through the cooperative medical scheme. You had a 3-tier system that existed during the first 30 years after China's revolution. That had broken down, and now they felt that it was time to rebuild that. So the 2009 reforms focused on also strengthening the preventive and public health measures. So they had separate financing for separate preventive and public health measures like early detection, like surveillance of diseases, what was emerging, have more early detection for non-communicable diseases, because China was facing a heavy burden, had started facing a heavy burden of chronic diseases by then. So a whole lot of measures to help to overcome the distortions that were actually created by their earlier reforms. There was also like the budget allocation ideally should be tied to the needs of the population and the facilities, but is linked to fiscal capacity at the local level. So changes in revenue generation within hospitals did not bring down costs sufficiently. I mean, in the sense, this was the hospital itself was so dominant in the Chinese health services that it was very difficult to rebuild this primary health services, because there were a whole lot of challenges that still existed, and there was a path dependency that was created. So despite the fact that the primary health services was being restructured, the flow of the patients to hospitals didn't stop. So gaps remained. There was like less personnel in the primary health services who were not very well trained. There was a fragmentation between public health services and clinical services, and therefore the continuity of care was still a challenge. So if you look at this diagram, you will see that this is actually a 2020 data. It shows that instead, this is an inverted pyramid. So actually the pyramid should be straight. So where you have the base, where the primary healthcare facilities have more resources, then the secondary, and then the tertiary. But China still faces the challenge of having a heavy load at the top. So this also meant, like, the reforms of bringing the primary health services back as a central point of the health service structure also meant that you needed more health workers at the primary level. So now how do you do that? I mean, to encourage more people to join the workforce, there had to be something that the government needed to do in terms of incentivizing people to come to work at that level. So they started subsidizing a lot of the education of people who were willing to work in rural areas, who were coming from rural areas. And they introduced a whole lot of different schemes and enrollment criteria for students who were willing to join from rural areas. So these are kind of reforms that they brought to even build a human resources cadre at the primary level, but they have still a long way to go, because there still exists, the shortfall still exists, and retention is also an issue compared to their urban counterparts. So in the sense of when we look at the pandemic, I mean, this is again something like one could argue that this might have happened, like while they were positive reforms, I mean, they have consistently worked towards investing more in health services, investing more in rational care and a more dominant primary health services. The pandemic, in a sense, highlighted the shortcomings of a fragmented health services. And this has, I mean, that's why I'm saying this is like, I'm taking a case of China, because this has happened world over, and every country, in a sense, has been exposed to this thing of having fragmented health service delivery. So despite the widely promoted value of preventive and promotive care, most systems have neglected the primary care. And the frontline component to fight against infectious disease as a whole have been a major challenge. So in a sense, a primary care is critical point for triage. Basically, you're trying to triage patients, sorting patients at the primary level, and then checking who needs hospital care and then referring them to hospitals rather than patients themselves directly crowding the hospitals. So there are infectious diseases like COVID and any viral infections can be treated at the community level. And even in COVID, we see that mostly people who have been affected by COVID have mostly been cured and treated at the primary level. They haven't needed hospitalization. There's a small percentage that needs that. So the widespread outbreak of virus has also brought in the aspects of what happens within long-term care homes, which we have seen in the West also. Because given an elderly, I mean, the demography has also changed. There are elderly population, the percentage has increased, and China is one of those countries where demographically it's kind of had seen the transition now already. And there are long-term care homes even within the country. And there have been instances when Shanghai was facing their lockdown last year, and when they went through the severe Omicron wave in February and March, there were many elderly who suffered in the long-term care homes, and there were devastating impacts, revealing that the limitations of the health services. And of course, the underlying comorbidities that the elderly have faced all over the world, they have had to be protected much more because the rapid increase in non-communicable diseases, chronic infections in the last 2 decades have actually also risen because demographically there has been a shift, and the elderly population has been suffering more from these comorbidities. When we look at financing of health services, I mean, China has done reasonably well, but it could have done better in terms of being a middle income country and the way it's progressed in terms of how it's invested in its health services. So government expenditure, if you see as part of total health expenditure, has definitely increased. Like they've increased it from 15% in 2000 to 28% in 2020. But their maximum increase has happened in social insurance schemes, so which is contributory in most cases, but government also subsidizes for those who are self-employed or not employed. So almost 44% of the total health expenditure, I would say, is from social insurance schemes, which are contributory from employee, employer, and individuals who have paid to be part of the insurance schemes. In the process, what's happened is that the out-of-pocket expenditure has reduced because China faced an high out-of-pocket in the early 2000s, which has come down to about 30% lately. But of course, it's a fragmented financing system. It's not completely a tax-based system. In terms of progressive financing, when you're looking at health services and health systems, a tax-based system is what works best. Is considered progressive. But increasingly, we see that in the name of universal health coverage, insurance schemes have become the dominant form of financing. And that, in a sense, does fragment the system. It kind of delinks the preventive from the curative, because insurance generally just covers curative services. And there are inequalities in insurance schemes, and China faces the same. They have inequalities across income, with people in formal employment getting much better coverage and benefits than a farmer or someone in the rural village who would be covered by the government insurance scheme, probably with heavy subsidization, but still might not get a similar kind of coverage. So costs of care still remain high, and the funding is regressive. So despite these improvements, there are substantial differences between the lowest and highest income groups. These differences are attributable to the large differences in insurance benefits. So again, if we look at the pandemic, it has actually highlighted, again, it's a global phenomenon. It has highlighted the weakness of contribution-based health financing and reiterated the need for governments to directly finance essential health services. So the government in many countries and even in China have retreated from preventive and promotive health services, financing them properly. China, in fact, is still getting back to it, and they have taken a step towards financing the preventive health measures. But insurance schemes in that sense tend to focus on curative care, and which makes them and the focus becomes so much dominantly on insurance schemes that you actually become ill-prepared in a sense to tackle public health crisis when it emerges. So insurance systems are also deeply entrenched, have become entrenched, especially in the quest for universal healthcare. So China already has seen penetration of private insurance also over the last decade, along with its social insurance schemes. In future, I expect there'll be an increase in private insurance schemes within China that appeals to the upper middle income population. And these are deeply political and will expand gradually. Now, if we look at governance, what was happening in the governance segment in China? So pre-2018, actually, China had a pretty fragmented system of governance when it comes to health services. So you see different agencies working, multiple actors, financing. Financing is, of course, Ministry of Finance, which is MOF, the Ministry of Health. Then you had the National Development Reform Commission. You had the 3 insurance schemes, which is NCMS is one, which caters to the rural population, the National Cooperative Medical Scheme, and the 2 urban insurance schemes that were managed by different agencies completely. And then you had a medical assistance scheme, which was again being administered by the Ministry of Civil Affairs. So you had a very fragmented, and the dispersion of power, as this image shows, between ministries and public hospitals is quite clear. And the coordination definitely had its effect on efficiency and equity and in a sense of comprehensive services were rare. But this is even before COVID, so 2000, but this was something that was constantly that they were debating on within the government itself. Like, this is not the fragmented system was actually affecting the outcomes. So they realized it much before. So 2009 was again a time when they were gradually thinking of how to merge institutions and make it more viable. So what they do in 2018 is they merge. So this is before 2018, and these four institutions, these four departments in a sense, and ministry, whatever aspect of health services is there, they kind of bring it under one agency, which is the National Healthcare Security Administration, so the NHSA. And then there's the National Health Commission, which actually oversees the Ministry of Health's planning, policies, and they have the China National Aging Committee, and then the Ministry of Industry and Information and Technology. So technology has played a huge role in the health services, so even that gets integrated. Now, the thing is, like, so China also has a central disease control and prevention agency, which played a big role during the COVID, which is again supervised now by the National Health Commission. And during the COVID pandemic, they also introduced in May 2021, the National Bureau of Disease Prevention and Control, which is also under the administration of NHC. But in a sense, this also fragmented the two departments. So each one didn't know as to which one was doing which work regarding the pandemic. The local governments responsible also. So in a sense, you see merging of institutions, which had a positive effect in terms of its efficiency and ease the administrative functions. But these weren't directly, what studies show that these don't actually percolate down to the middle level administration and the local government agencies. So local governments responsible for financing and provisioning of services have their own agencies and health departments at various levels. And the central government provides more funding to provinces that are less developed, mostly the Western provinces. Subsidies in the more developed Eastern provinces come mostly from the provincial governments. So like a city, like a place like Shanghai would have their own municipality, which is one of the richest municipalities you have in China, which takes care of the health services. So most of the funding is from the municipality, and the central government gives very little funding. There is a high degree of fiscal decentralization also and autonomy given to provincial governments. And the central and provincial governments are responsible for the broader policy and strategic design and investment in the larger infrastructure. So in the midst of the pandemic, you see emerging of newer institutions like this. You had the National Bureau of Disease Prevention and Control, and you already had the existing Center for Disease Control, which already operated. In this case, it created a confusion as to who is accountable to whom. That became a sensitive question. Another significant observation made by scholars is like the NHSA, which is the National Health Security Administration, and the NHC are mostly at loggerheads with each other because both are equally powerful. The NHSA has the hold over funds, and the NHC has the hold over policies and decision making. So in a sense, one is a purchaser and the other formulates policies and oversees delivery. So one has the greater financial control, and both yield a lot of power, but kind of don't get along. So again, coming to COVID, many health systems were considered strongly prepared in terms of infrastructure. So you had these better health performing countries who were graded or ranked in the sense of like, okay, this country would do, assuming that these things are in place, they would do very well in response to COVID, but that COVID years actually showed that they weren't able to respond in that sense. They did not fare well in responding to COVID-19. It actually tested the usefulness also, the pandemic particularly tested the usefulness of decentralization and administrative autonomy during the public health crisis. So if you see like the centralized systems of China, Singapore, South Korea, in a sense, had an effective response initially, like the first year of the COVID and all, you see they get control over the decisions and all, and kind of then that percolates down to the local and the provincial level. So in a sense, like decentralization is a conducive factor, especially during these times when national level preparation and coordination mechanisms are effective. So I would want to, in a sense, 1 second. Stop sharing this. Sorry. Yeah. In a sense, I would just like to conclude that the COVID pandemic has demonstrated. Can you still see the slideshow?
No, Madhu, I think.
Okay, fine. Sorry, I was a bit confused. Yeah. Okay. So if I just want to conclude by saying that the COVID pandemic has demonstrated that the need for building, I mean, that's something like the WHO has also come up with, like building resilient health systems. So what does resilience mean in the context of COVID? So we are also looking at existing systems which are robust, which can respond to a crisis like this and can adapt to something that's coming underway. So in the sense, so you have to have a robust system to even adapt to something, a time of crisis. So China did offer some unique experience. I mean, every country did, but China also had its share of successes in the past. I mean, in 2020, I think they effectively were able to curb the spread of infections within their country. They did engage in strict community management to pursue a zero COVID strategy. Of course, there's a lot of questions on the zero COVID strategy, how it works, why does one decide on it, assume that the benefits would outweigh the costs of things, it would avert deaths, but when does one actually exit from a zero COVID strategy? So I would say there's no one perfect strategy that the country has taken. It's a lot to do with the context and the decisions that country makes, which could be also political. China was also able to increase the workforce capacity, the frontline workers, and this was enabled by the CPC to mobilize a range of stakeholders to work collaboratively at the primary level. So basically, if you're doing testing, you are administering, starting with fever clinics, and you have some trained human resources for that, and a whole lot of frontline workers doing all kinds of different way of delivering services to the population. China also responded, like in a crisis like this, I mean, one would assume like every ministry would take up the role of as a health ministry, like every ministry has to get oriented towards the crisis of responding to the population, responding to its citizens. So they actually had 32 ministries which were kind of brought in together to respond to the crisis in terms of communicating, collaborating, even mobilizing resources. Primary care was an integral part of this massive community response that they had, and it provided various functions. They also, we know that they did develop those makeshift modular hospitals in the beginning, which are called the Hansang Yuan. In a sense, like these were brought up within 12 days, they were able to create these hospitals. And a lot of the other countries actually learned from China in a sense as to how to, take care of like population, a sick population, which is growing in numbers by the day. Also quarantining a whole city, that was a lesson one learned from China, like Wuhan was completely quarantined for over 72 days or something. And many countries did take up that gradual way of, quarantine. We undertook a massive lockdown. I mean, which was not just about a city, but the entire country was under lockdown. And these were some instances that some of the other countries also followed. But of course, I mean, there have been, China's existing systems also show that there are challenges still. They are exposed. They were exposed to its limitations in the sense of there was lack of early detection initially. There was lack of gatekeeping due to weak primary health services. So in Wuhan also we see that there was a lot of heavy load of cases in the hospitals since there was limited capacity and weak integration of services, medical care and public health at the bottom. Then reforms in governance have been critical considering the center-province dynamics. There have been different responses from different provinces. Fragmented authorities and overlap of some services have led to territorial disputes earlier, but now you do see during COVID, once the zero COVID policy strategy was taken, the central government obviously took the larger role in that sense. So China's journey also shows that's something also in the past that we have seen, that understanding local contexts and variations are critical for effective services. So the health services also demonstrate that. One of their important things is the implementation of making reforms through pilots. So this helps in making them context specific for better results with variations across provinces. So these pilots, once the lessons from the pilots become apparent, they kind of scale it up. But also the problem there is we really don't see much evidence coming out of these pilots. Some pilots have focused on financing, on strengthening primary level services, creating referral systems, creating essential drug lists, also health technology, how to use technology during times like this. But while piloting is followed universally through across provinces, there's lack of rigor one feels in designing and evaluating pilots. So we really don't come across an evaluation of pilots and, in a sense, why the scaling up happened, based on which the scaling up should have happened. So piloting could be an effective strategy for delivery, but they must follow rigor or design, followed by evaluations. The private sector in China has a much limited role, but has been given more space in the past decade. And I see in future it coming up. Probably it's also been in the last few years that, especially the COVID years, might create some restrictions on the growth of the private sector, but one doesn't know how it's going to grow. Strong public sector, I see I see in the future that China would be strengthening its primary level services further, probably will go back to stronger epidemiological stations and surveillance measures in place. The challenges of a hospital-based system will probably stay because that's something that's really complex and they have not been able to break out of that challenge. And insurance systems will also remain, and probably the fragmentation that way will remain. To end, China has made several substantive health reforms in the past 2 decades, but there are still concerns over fragmented information systems, rigorous evaluations and accountability mechanisms, quality of primary level services, and an overall equity of services. China's experience, however, underlines the importance of an ongoing assessment of health systems and the viewing of reforms as a continuing and evolving process. And this we have seen consistently over the last 2 decades. And this strengthens the positive outcomes and addresses the negatives of each set of reforms. And they're also willing to learn from their own lessons. That's what I feel that they have done in the past too, and probably will do now. Thank you, and I'll wait for the questions. I think I've taken a long time. I'm sorry.
No, not at all. Not at all. I think given the nature of the subject and given your fascinating breadth of issues, very, very informative and thought-provoking, Madhu. I was fascinated by this whole account. Of course, you were with the Institute for a long time and we had opportunity to hear you often, but I think this particular issue that has obviously gripped the world, we really need to do much more thorough look at China, given the sheer nature of the number of people that are involved, and particularly for us, given that we have equal numbers. All the issues that you were mentioning, particularly how they have once again realized the value of the primary sector and what is going to happen. So just with one comment, I'll open up the floor. See, the thing is that once you actually open the genie of privatization, and you can see that the rapidity with which the urban metropolitan systems multiply, expand, and gradually engulf the state-run sectors, state-run institutions. Is it possible to put the genie back into the bottle, as it were? I mean, what kind, you can give incentives to individuals to try and bring them back to the primary sector, but what incentives do you give to these private players who clearly are not going to, unless of course the China being a very different system, can crack the whip and say, you jolly well do this. So how does one come back to that business of strengthening the primary sector and ensuring that you are actually taking care of things there, which then prevents that cascading effect that then. So that's just the broad kind of thing which I had in mind. And Amit Dogra has put up his hand, so let's have his question. And somebody will help me navigate these hands and comments so that.
Yes, ma'am, I'm back.
Okay, thanks. Okay, Amit, you can take it. Madhu, you let us know whether you would like to take one at a time, or would you like to sort of take a clutch of 2 or 3?
Yeah, I could take one at a time because I think there'll be different
All right.
questions. And,
so would you like to then respond to what I asked? Or
yeah. So yeah, I mean, this is an important question actually, because which actually we have also been looking in our work, because it seems because the public sector is so dominant in the Chinese health sector that you see a lot of scholars actually gloss over what's happening with the private sector and with private capital in that sense within China. And this has definitely grown over the last decade. And in fact, in our book, that's why we have a separate chapter on this, just to show the trend of this growth that has happened in the last 20 years. And it was never that the private sector didn't exist. It always did exist, even at the primary and probably a little at the secondary and the tertiary. But in pharma and medical diagnostics, it always did, especially post 1980s. So, and that's what we say. I mean, we are getting into a medical industrial complex kind of a situation, and China is also heading towards that. I mean, this was used in the context of USA way back in the 1980s. But we see every system in that sense. I mean, even we are, as a country, probably moving towards that. But even China being largely socialist and government is dominating that system. But you see the complexities of the insurance plus the pharma industry, the diagnostic industries, and now the private capital in infrastructure and provisioning, as well as capital which is entering the public hospitals, in the name of partnership. So these are kind of here to stay, because you also have a large, and also insurance companies, private insurance companies are very much there in China since the early 2000s. So, and you have an upper income, mobile, socially, in their, coming up in their social mobility, and, they have larger incomes, and they are also demanding to have these kind of whatever. Private sector is also has become synonymous to quality care, but that's a big question. I mean, how do we define quality, and whether the private sector actually is that? But in a sense, these urban cities, the first tier and the second tier cities, is where this private sector is expanding, and not just the expansion of the private provisioning, but also private capital coming into public hospitals and public institutions. So those are interesting things that are happening. But I've also heard scholars saying that post-COVID, I mean, China has always also put the reins on the private sector. It's not so easy, in the sense for at least outside companies, private investors to enter Chinese market in that sense. So they do kind of hold a whip, as you say, but we don't know post-COVID whether they'll be, I'm assuming they might just be a little more careful as to where they're investing now or where they're allowing the investments, but it's not like it's going to stop. It's going to, especially during the time of Xi and all, because last 10 years has really seen a growth in the private sector. So definitely the complexities will increase. Yeah.
All right, thanks. Yeah.
Yes, Amit. Yeah.
Okay, so our first
Am I audible?
question in the chat box is from Siddharth.
So
From
I thought
Sugandha, can Amit ask the question? He
yeah,
had his hand raised. So
yeah.
we can go back to the chat box after he has asked. Yeah.
yeah, sure.
Am I audible?
Yeah.
First of all, thanks for that enlightening session. I was wondering, as you have pointed out, that we are getting back to the primary healthcare sector, but in the rural areas where there are not much developed health facilities, how has the traditional medicine has come up as an effective response against the COVID treatment? As we have seen in India during pandemic, we have a lot of Ayurvedic brands. They come up as effective treatment. So was there a similar situation in China regarding the traditional medicines as we have seen in India?
Yeah, that's something I would only speculate because I haven't come across much literature on what was happening in response to traditional medicine. Yeah, I mean, in India also we had the separate, and the Ayush Ministry also playing a role in the policies and responses to COVID. But I'm assuming China also, it would have played a big role because traditional medicines do play a big role in the lives of Chinese people. And a lot of the primary level, like this is not the public, but the private level medical professions or people who actually provide with some care to the population are actually traditional healers in that sense, or traditional medical practitioners. So I'm assuming that would have been one of the greater things. But even China has a policy, very specific policy for traditional medicine, and they also try to integrate it to or mainstream it with the modern allopathic medicine. But in a sense, we also don't see, I mean, in some cases, the two kind of probably do talk to each other at a level, but you also see them like co-located in institutions. So you have a traditional medicine floor like dedicated to traditional medicine where people can access, but you also have the allopathy in other floors, I mean, in that sense. So in that sense, there's a kind of co-location that's there, but not proper integration of these two medicinal systems either. But yes, I'm sure it would have played a big role, but I haven't come across literature, much literature on that. Thanks.
Thank you.
Should I go ahead with
with the chat questions.
Yeah. Okay, so the first question is from Siddharth, who is from a Red Lantern Analytica, which looks into Sino-India developments. The question is, given the recent wave of China, although everything is open now, do you see an eventful shift coming where it won't remain within quotes manufacturing backyard of the world?
I really don't know whether I can answer this question, but by going by what I've been reading, like, yes, it's already, the shift has been there in the sense of the manufacturing backyard shifting to Southeast Asia, countries there like Vietnam and Laos and Cambodia and all these places. But I wouldn't say that it would stop so soon also, because China is kind of coming back now, back to being its earlier self in a sense. I mean, once it's out of this wave, the COVID wave is already, we know it's already hit the peak and it's coming down in that sense. So it might still be the forerunner, but then there are other countries who have now opened up to being the manufacturing, taking up the role that China has been unable to play in the last few years. I don't think I'm like confident about answering this question. Yeah.
Okay, so we'll move on to the next question by Aprajita Sarkar. I was wondering how the out-of-pocket expenditure came down in the recent years. Also, what do you think about the lasting impact of COVID on China's health governance? I have in mind the Arogya app that has now been turned into digital health ID.
Yeah, thanks, Prajita. Yeah, the out-of-pocket expenditure has come down, but that's the thing with what happens with insurance schemes, especially in the case of China, where we see universal insurance scheme. I mean, it's covered over 98% of the population is covered by insurance. It's also, these insurance schemes are actually taken into consideration only the curative health services. But you also have the government putting aside dedicated funds for individuals, like about 15 RMB per individual for preventive and promotive health services. So in that sense, that's also integrated with the financing. In the sense, so I don't know how it's worked, but obviously because the insurance schemes have been, I wouldn't say they were efficient, but they have been out there for a long time, for the last almost 15 years. There have been like the catastrophic expenditures and all have come to a decline. But because the insurance also plays in a commercial environment, because as I said before, that the public hospitals are also still commercial, are still generating their own revenues. That hasn't come down, even though the government subsidies have increased to some extent. The commercial nature of these institutions have really not declined. And that's where I say at the end, like, I don't see that happening anytime in the future, that they're being completely subsumed by government funds and all. So in that sense, I feel that the costs are still high, but because insurance is providing for people and there's so many people covered, that might reflect in a lower out-of-pocket expenditure and the lower impoverishment due to medical expenditure, and therefore that reflects on low out-of-pocket. But that's the thing, like even if I'm saying 30% out-of-pocket is still there, it's pretty high in terms of absolute terms. So it's not really, the costs are really not in that sense low. And China's health governance, yes, I mean, China has been, I mean, if we take the instance of digital health, I mean, it's a highly technology-centric health service system again. So that's another, in a sense, I mean, that could have a negative impact on a health service system when you are very technologically oriented in that sense, because sometimes health services or response to health infections and all doesn't actually need such high-tech interventions all the time. So in that sense, digital health and telemedicine, that has actually been one of the things that even China has had kind of adapted to during the COVID years. I mean, they really really went forward with distant remote health consultations with the population, and also that was getting to be quite popular. And I see them going ahead in a sense with probably they already have a digital health ID. I'm not too sure, but with their social credit system and all that, maybe that would also be integrated with that, as far as I know. So I won't be surprised if they have already some system in place. But in terms of, so that would obviously percolate from the macro to the micro in that sense. And every province again will have its own way of keeping this digital or technological advances going in that sense. I don't know whether I answered the question, but Shubhadeep has his
We have a
raised.
raised hand option. Yeah. Shubhadeep.
Thank you, ma'am, for this enlightening session. My question is regarding that you have shown a graph where China's main interest has been moved to upward at tertiary health sector.
Hmm.
The amount of the collaboration of the patient and the dead bodies in the that we have seen in the during the recent peak that we have seen in China. So my question is that the similar type of thing we have seen during the first and second wave in India too. So is it because that India has also moved out from the primary to tertiary level of the system? So that was the case, or something else? If
Yeah, I mean, that's the thing. I mean, in this sense, I'm like looking at China as a microcosm of what's happening in a sense to a lot of countries. And so India definitely is one of those countries, again, where we have a very weak primary health services. And we are also kind of now negotiating as to how to strengthen the primary health services. So that again at the cost. So we have also created that dependency on a hospital system. We as people also don't have a sense of like we need a physician, or we need to get into a primary health center first, and get so because there's never been an access to a primary health center in our lives. We always land up going to a specialist or a doctor based in a hospital or a clinic or a private sector facility. So in that sense, the primary is, of course, ours is pretty much broken. And we have woken up now to the fact that, the primary health services need to be built. We are again a very top heavy system where we also land up visiting a lot of, AIMS is supposed to be a referral hospital, but you see the amount of, the number of the volume of people who land up in AIMS, because obviously, because the primary level services in different states are actually broken or non-functional. So, these are systems that every country, so primary health has become one of the major components in these COVID years. And you will see a lot of documents that are coming out now to say like, this is the time when needs to go back. This was always being said, but the COVID has kind of just made it so much more, prominent that this is what we all failed in that sense.
Ma'am, I just a follow up for that. Ma'am, as you mentioned that they have started to move to a primary, so that means China has started to invest more on the primary health center. But we, in terms of India, we have seen there is a cut in actual spending of the health sector. So how far do you think that will actually make any sense if we are trying to move to a primary, but at the same time we're reducing our expenditure?
Yeah, that's right. That's a good question, because that's where we are in a head, because we don't see any enhanced funding in our government health expenditure. So that's why we are also venturing into partnerships with the private, even at the primary level. So that's where the funds are going actually, or that's where the funds are coming from. We expect that to happen. And we are also going through this whole thing about having insurance schemes which are pretty much fragmented. So you have now the PMJY for the below poverty line people, but you are left, the rest of the population is left to kind of buying and purchasing their own insurance schemes as they wish to, unless you're formally employed and covered by your employer. So, there's a whole lot of like complexities here also. So the private sector, for us, the path dependency is the private sector, because in the sense we have a legacy of a private sector that is not regulated. And we are entering into partnerships with them also. And we ourselves, the public sector itself has never kind of taken measures or steps to regulate it in a big way, or, kind of cracking the whip that now is the time, like, we don't see that even happening now. And the private sector, in a sense, also failed to provide during the COVID years. We see that very clearly, that, it was the public sector which was taking the greater burden of patients and providing services, and all. The private was just too overloaded, and we're just catering to few people who could pay for their services. So we have a long way to go, or even figure what we want to do in terms of equity and universal care. Yeah.
Thank you, ma'am.
So Joy, you can go next.
Hello, ma'am.
Hi.
Thank you, ma'am, for the fascinating lecture. I have one question regarding the how politics save the health service development, and also the health policy, which you have already said in the outset of the lecture. So, if we see in context to India, then there is a rise of insurance scheme not only at the national level but also at different state level, and which is coming out of the particular rise coming due to the rise of populism, that to
Mm.
increase the popularity of a certain political regime.
Mm.
So both at state level and also at national level.
Mm.
And the way the insurance scheme and policies have been projected, but if we see the implementation and the effectiveness while it comes to health service delivery and protection financially, it is very much less.
Yes.
So I want to know that what is happening in context to China, that is there any sort of populism which is driving health sector in shaping the health policy and health service development in
Mm.
different political regime.
Well, yeah, I mean, it's a good question, actually. I mean, India, of course, I mean, you're right. I mean, there's a lot of populism around insurance, and you see a lot of state level health insurance schemes that have emerged, uh, catering to the BPL, providing some bit of coverage, and which are not deep enough. But China, I think, in a sense, always had a health insurance scheme in place. I mean, if you look at it historically, also, even during the Mao years, I mean, insurance was in terms of the cooperative system giving work points to individuals. So it's a collection of work points which are getting pooled in to the cooperative medical system. And in a sense, there's a co-payment, like the people pay a little bit of money and the work points also add to the funds of the facility that's working. So in a sense, that's fascinating because the insurance scheme existed uh, since then. I mean, if you consider that an insurance scheme, because there is co-payment and funds involved from the community, from the collectives that's coming in. But of course, that was a non-profit based. I mean, it wasn't like there was any profit motive in that. China's health insurance kind of expanded. They tried to universalize it only in the early 2000s. That time, I feel it's also, I mean, China is not, in a sense, not affected by what's happening globally. Of course, it's affected by what's happening globally. It also learns a lot of its lessons from the West. It's also very West looking in terms of its policies and what's happening. And you see a lot of these. So this is like the post reforms kind of a development that's happened, where you have the first generation of medical doctors like post 80s who actually went to the US, got trained, came back to China, formulated policies. China also invites foreign universities, academic councils, different groups of investors to design their policies, blueprints for the reforms, and then decide as a government what they want to do. And that's what happened in 2009 reforms also. So in a sense, there are contradictions in the reforms. So even if they want to build the primary sector, build the primary level, strengthen the system, they also have an insurance scheme which is very curative focused and which they can't. Now it's like there. So it kind of disintegrates from the primary because it's just looking at curative services in that sense. So, but they are trying to work around that. I feel they're also trying to integrate. I mean, that's what I feel happens with the Chinese system, because they learn from their own mistakes. They try to rectify, but in a system which is already so complex, it becomes very difficult to overhaul it in a sense. I mean, so you do these incremental changes of, okay, you increase a bit of funds, you're trying to incentivize the human resources to work in the rural sector. You're trying to increase the depth of coverage so that the insurance scheme is more equitable in that sense, and I mean, equally across the population, rural and urban. So those are the things. So those are the amendments that they try to make, but obviously those are not completely reforming the system that way. I'm sorry, I lost track of the thing. Have I answered it or?
Yes, ma'am. To some extent, I
To
have
some
got
extent.
your point, and
Yeah.
yes, because if we
But
see
the
that,
insurance itself has its problem, and that's seen in countries. So China, I would say it's also like because there are no, I mean, the insurance that is run by the government doesn't have any for-profit interests in that sense. But the problem is that the hospitals work commercially. So once the system is already in a sense commercial, so they create a demand for more patients, more prescriptions, more diagnostics, more providing more care. So despite the fact that the insurance might not have a profit motive, or the insurance mechanism is like not being ruled by the private market as in India, where you have the third party administrators who have their own agendas for profit making, that might not be there in China. But the hospitals, public hospitals themselves have a very commercial way of functioning. So that complicates the insurance model, and that's the reason the costs are still high, and the costs are rising in China. So it's not like medical care has the costs of medical care have come down. So even the out of pocket has come down, the costs are still high.
okay, ma'am. Thank you, ma'am.
I think we're done with the question answer round. Ma'am, would you like to make any concluding remarks?
Well, me or Madhu? I don't think there are any concluding remarks to be made here. In fact, what we should be thinking about is Madhu's next talk here. You opened up you opened up an entirely new set of issues which require. I think we need to look into this much more. I think when we there was one question about implications on the economy, and then there's obviously another question on other questions can come in talking in terms of the security strategy. I think the health of populations is increasingly it's increasingly necessary to see this in the context of the non-traditional threats to security. I mean, if you have something like um, a good percentage of people who are lacking, I don't know how would you what kind of percentage would you give this, but certainly a quarter of the population easily not having access to good medical services and care and so on. How are we really evaluating? And that first slide of yours, which showed us the infant mortality, I think we still have a long way to go there. So this is an issue which needs to be studied more carefully, particularly in terms of the lessons to be learned. What are the good practices, best practices that we must incorporate? Because the objective aspects are quite similar. And if you look at large populations, existence of poverty, existence of lack of basic amenities, and really the far-flung areas and so on. So somewhere I think what we need from you now is another on another talk on the what we really should be looking at when we what are the kind of lessons that China offers, and a much more exhaustive kind of way in which we look at these. That would be my way of my closure. If you have any final thoughts to give us before we call it a day.
No, no final thoughts. It's just, I mean, in fact, the working paper I done on China was actually kind of also the reason that I was doing it was to look at lessons. I mean, in general, look at lessons for health systems, of course, for India specifically, but also in general, overall health systems across, what have they, and what are the limitations also that they have. So lessons in terms of the negatives, also the positives that they have taken. So that's something definitely I'm still working on. So probably sometime later I would want to. But I think you also had, when you opened the session, you also had talked about a lot of other things about the zero COVID strategy, about this and that. So I think, in the sense, I mean, those questions remain unanswered because I went back to health services and then I came back to the present. And also, I mean, there's really no single answer for that, because a lot of the responses in the last 3 years, and that's seen globally across countries, has been very ad hoc that way, you know, because I mean, even science didn't have answers for a lot of things. So it was left to the countries' own devices as to what you think would be beneficial for your population and protect them. And zero COVID strategy was also something that many countries took up. But China, of course, stayed on with it for various reasons, for political reasons, for probably the reasons of these challenges that I'm talking about, not knowing like how to handle a population which falls sick, which is now it's doing that. I mean, it's almost 80-90% they're saying will actually now kind of get COVID. And then, you know, the peak is already over, I feel. I mean, they're already on a decline now because it was so fast that they, I mean, the thing spread. So I, or maybe just out of fear of how to exit, because exit itself, exiting from a zero COVID strategy is a, I mean, important thing. How do you think, how do you, you know, strategize something like this? And do you do it gradually? I mean, China just did it suddenly. So would you have preferred if you had done it like, you know, gradually, province-wise? Or, I mean, so there are no perfect answers for this. I mean, Australia and Singapore and New Zealand all did away with the zero COVID strategy, but they also faced the surge in phases, and you know, it's not like they were, you know, bereft of it or didn't have any infections or less infections. They've also had their waves of COVID and also. So I guess China is just going through what we, as you said, went through our second phase. But probably they're lucky it's the Omicron, because I mean, I'm assuming there won't be so many deaths as we had during the Delta. And
yeah. In fact, I do recall at the time of Delta that there were many commentaries and assessments that probably the zero COVID would have been better off had we followed it during the Delta wave. It wouldn't have been COVID. But anyway, I mean, as you said, these are questions which to which there are no definitive answers. We make our mistakes as we go along. Let's just all be glad that pandemics happen once a century. so thank you.
And let's be prepared for the next one.
The next
That's the lesson for.
Thanks a lot, Madhu, and we are really going to look forward to your second.
Thank you.
Which is
thank
work
you so much. Yeah.
with us. And thank you all for joining us today. I hope you all had as instructive a time as I did. Thank you.
Thank you.
Bye.
Bye.
Have we stopped recording?